Good morning. Yeah. Good morning to you all. Welcome to the Health and Care Overview and Scrutiny Committee, being the 27th of January 2025. We are here in the Oak Room at County Buildings, and the meeting will be streamed live and will be kept in recording for 12 months. So welcome to those who may be listening. If I can just go straight to the to the agenda, could I have apologies, please?
Good morning, Chairman. I've received apologies from Councillor Hood, Councillor Presswood and Councillor Legg. I also note that Councillor Hewitt will be arriving late.
Just a note regarding Councillor Hewitt, he's representing the County Council and us at a Holocaust memorial this morning. So I think we ourselves will spend a few moments, I'm sure, throughout today of the liberation of Auschwitz, being the 80th anniversary, and obviously being the Holocaust anniversary. So we will pay our thoughts to that. Item 2, declarations of interest. Do we have any?
Yes.
Bernard?
Governor at UHDB.
Anybody else? Anne?
Partner Governor from the Stafford County Council on Midland Partnership Foundation Trust.
Okay. And obviously if anything comes across in the next, so we do declare it if it comes to mind. So we have the minutes of the meeting held on the 2nd of December 2024. Can I approve those as a true and accurate record? Okay, thank you. Thank you for that. So if we can now go into the main part of the agenda, and we've got the staff's system level access improvement plan. So it's a report by the Staffordshire and Stoke Integrated Care Board. Welcome. If I'm right in thinking, we've got Tracy Cox.
Yes, that's
Mark
me.
Stone.
Yes.
And
Vicky Oxford.
thank you very much. Okay. If you could give us your report, and then we will take it from there. Thank you very much.
Thank you. So, good morning everyone. My name is Tracy Cox. I'm the Associate Director for Primary Care for Staffordshire and Stoke-on-Trent ICB. My two colleagues today have joined me to come to present a year on, actually, the System Level Access Improvement Plan. So you've got a copy of the plan within the pack. I'm not going to go through that plan in detail. I think we kind of took you through that last year, but what we did want to do today was to kind of present some of the kind of achievements, I suppose, celebrate some of the things, the improvements actually. But you will recall we did present the plan to you last year. The plan was drafted back in November 2023, and that was in response to the National Recovery Plan around primary care access. The latest plan that we're presenting today has been through our board for assurance purposes in November, and it was received really well in terms of the progress that we updated. So what I will do is just take you through kind of a few key points, and then I'll hand over to Mark to talk just a little bit about some of the detail around digital and skill mix in general practice. And then I'll bring you on to a bit of an update around pharmacy and a few key points to leave the meeting with today. So the core and centre of this plan is around improving the experience of GP access for our patients. So patient satisfaction is really key. So The patient satisfaction results for 2024 from the National GP Patient Survey actually showed an improvement for Staffordshire and Stoke-on-Trent. And we were one of the few systems actually to see some improvement within those survey results. Overall satisfaction has improved from 73% in 2023 to 76.3% in 2024, and that's against the national average of 73.9%. What's also positive is that we can see that patients have reported, 88.9% of patients have reported a real good experience with their community pharmacy as well. And our ICB also has a higher percentage of patients that have reported being able to contact their GP by telephone as easy compared again to the national average. So we're starting to see that movement in our patient satisfaction results. And you may know that the National GP Patient Survey is actually out again at the moment for this year. I think that's until the end of March, and we usually receive those results in around July. So what we will be doing is really looking closely at what those results are telling us, not just in terms of overall results for our Staffordshire and Stoke-on-Trent population, but also drilling down in terms of that variation piece across practices. I certainly know that was a question that we had when we came to present that last year, and that is something that we do in terms of looking at that variation and supporting those practices where we do have that real variation. Numbers of improvements have actually increased since we started the plan by over 200,000 appointments. From a digital perspective, there is a lot of activity kind of going on within that digital space, and it is becoming more embedded in terms of enhancing access in our GP practices. So patients can now access their medical records digitally via the NHS app if they choose to do this, compared to when we first started that journey when minimal numbers of patients were accessing through the NHS app. And we're also seeing improvements to the telephone systems as well, which I'll ask Mark to kind of pick up on in a few minutes. We've trained and continue to offer training to staff in terms of that care navigation, and that's to ensure that patients are seen at the right place, at the right time, by the right professional. And then from that workforce perspective, and I think we talked a lot about this last year, there is that broader skill mix now in general practice through the additional roles scheme. So there's lots of different professionals that patients can now be navigated to. And again, Mark will talk a little bit about that in a second. And then just the final key point from me is that we do have that ability to utilise our community pharmacies more. We do have the Pharmacy First scheme with those 7 key conditions as well. And we can see, general practice and pharmacy working much closer together. So I'll hand over to Mark, who's just going to talk to you a little bit about some of the digital and some of the skill mix, and then I'll come back in and talk a bit about pharmacy.
Thank you, Chairman. Thank you, Tracy, and thank you, Mr. Chairman, for the opportunity to speak. Just let me introduce myself. I am Dr. Mark Stone. I'm a local GP and one of the clinical leads for the Staffordshire and Stoke ICB. So looking at sort of the digital aspects which are occurring in primary care, this fits with modernising general practice, which is a national programme. Practices, I think, locally, all but 4, are now on cloud-based telephony. This gives us an opportunity to analyse our call data when people are calling in, look at those spikes in data. It allows us to look at how we can facilitate patients being able to access and contact practices. There's also a significant growth in other IT modalities such as online consultations, so patients don't have to phone up and utilise that method. So we're looking at how patients can easily get into general practice. There's also the NHS app that Tracy Cox alluded to, which allows patients to look at their notes prospectively, look at their results, so therefore reducing the telephone traffic into practices, because patients can access this information and take control of their own healthcare as we move forward. So a lot of this digital improvements is helping to release telephone capacity to allow patients that need to phone on the day to access general practice. With respects to workforce, We've seen a steady state of full-time equivalent GPs. We've got 729 in September 24. We've got a stable number of nurses. Where we've seen a significant change in the general practice workforce is what we call the additional roles reimbursement scheme, which fits in with our primary care networks. For those that aren't aware, primary care networks are where GP practices are working more closely together to deliver services to their collective patients. This has given us additional income and funding within general practice to diversify our skill mix and the professionals that we have within practice. This includes pharmacists, mental health practitioners, first contact physiotherapists, care coordinators, which helps to facilitate and work as a team across the practices to facilitate a better healthcare approach. One of the key bits that we need to see within this is helping patients navigate that particular landscape and change in that workforce, and we've been working on an additional program around sort of behavioural change, and that behavioural change is trying to help support patients with that change and the citizens of Staffordshire around that change, to support them in their decision making processes when they try to contact the practices, what clinicians they might want to see, and as Tracy alluded to, looking at the right patient, the right clinician at the right time for their particular care, because it's very frustrating, as you'll all experience, seeing a wrong clinician at the wrong time, because you've then got to rebook and get round that system. Thank you very much.
Thank you very much for the report. Quite a comprehensive report, but I'm sure from it we'll have some questions. So, Councillor Julia Jessel.
You know you've been eyed when the chairman looks at you as if to say, yes, you go first. Right. Good morning, and thank you very much for the report. And I think, first of all, acknowledge that it's good to see improvements are being made and some customer feedback. I find the NHS app very useful, very easy to use. So, you know, we'll start off on a positive. I've got a number of questions, so I'll fire them at you, and then whichever one wants to answer them. The first thing I want to ask is not necessarily about access to GPs. That's improved. You get referred for investigation, and then you have to wait weeks and weeks for the GP then to be informed to then get back to you. Whereas if it was a hospital referral, the staff will tell you there and then. So there is a discrimination in terms of referrals for investigations, that if you're a GP referral or a hospital referral, and that actually frustrates people because they're waiting weeks and weeks and weeks. It's great that there's a trend towards accessing investigations quickly, but actually it has a very negative effect on people, and I get fed this back by residents, that they then have to wait weeks, if not months, to get the result back via the GP. If it was a hospital referral, it'd be probably days, if that. So that's my first question, is why is there such a variation there? The other thing is, in the report, and I mean the Pharmacy First scheme has been up and running for a long time, even when I was in the NHS. And I think it is something that is really valuable, because people do need to be more self-reliant and use pharmacies. But the report actually says that some pharmacies are struggling for financial viability. Do we, you know, if that's the case, that's a flaw in the plan, because if there's going to be less and less community pharmacies, access is going to be more difficult. Do we understand why that is a problem? Is it purely through the pharmacy function, or most community pharmacies have a retail function? And is it the fact that actually the retail side, because you can go and buy pretty well everything else from your supermarket when you do your supermarket shopping, is it that's causing the problem? Because I think we need to understand that market, because if it's going to be a diminishing one because overall the shop isn't viable, I think we need to look at potentially providing Pharmacy First in a different way. The other one, yeah, and I've put, you know, I know some hospitals that actually have Boots pharmacies within the hospital complex. And that's the other thing. If community pharmacies aren't going to be functioning as a proper network, we need to look at other sites. The other thing is, you know, however much you improve the system, the one thing that's fairly obvious is we've got to reduce the demand because people are using it, both primary care services and secondary care, inappropriately. And I think we've lost the, you know, my mother taught me certain things, her mother did. That transference of knowledge about how to be self-reliant has been broken. And unfortunately, I think it comes down to education and schools to actually start to educate children at quite a young age. What are the basic things that you can have in a little kit at home? And actually, you know, you can, a lot of things you can deal with yourself if you know and have the confidence to do it. That is something that I think unless we pick up on, people will automatically, as the generations go on, just look to the NHS, the professionals, to deal with things that really they should be able to deal with themselves. When I read in the press, I think it was last week, the proportion of young households where they actually get somebody in now to change the light bulb because they don't know how to do it themselves. It's about a third. You know, we've become a highly dependent, less resilient society. As a county council, we're trying to change that culture through our social services. I think, unfortunately, and I don't like dumping even more onto schools, I think we need to start looking at that. One thing which is a little bit of a beef of mine, you've referred to the fact there's 750 whole-time equivalent GPs. Do you know what the number of total GPs are? I remember years and years ago, Tony Blair did a huge investment scheme in training. Yeah, even so. I know, I thought you might do, Steve. Yes, but you know, I'm one of these, give credit where credit due. But actually, they trained a lot more GPs, but they didn't get the number of hours out of them because so many work part-time. Now, I understand certain GPs at stages of their life, I worked part-time when my family were young. What do we need to do to encourage those GPs when they're able to go back and work more hours? Because actually, it's a lousy rate of return on the nation's investment. And as I say, I gave Tony Blair due where credit was due. Well, not the last, but with the IT systems that you're bringing in with GP practices, when IT systems are brought in, modern technologies brought in within industries, generally your administrative staff is reduced. When you look at the data, the administrative and non-hands-on clinical staff actually is increasing, I think, at a slightly faster rate than the clinical staff. It is something the public, you know, are now beginning to question. Why has the NHS, why are you increasing your administrative staff when actually you're introducing the technologies to have the reverse effect? And the last one, and I do apologise for that, but as you can imagine, I enjoyed reading through your report, is the Joy app, of which when I was cabinet member, I was involved in seeing that begin to roll out. There's obviously some really good feedback, and it starts off in Councillor Atkins' part of the world, due to Oxeter and Balance Street surgery. Is that being rolled out? Because that's an example of good practice, some innovative GPs who really wanted to change the way things worked. And is that being rolled out? Thank you very much for your patience. Thank you, Chairman.
Tracy, over to
Would you like me to start? I have made a list of as you went along. Apologies if I go slightly out of order with some of this, and I'll bring colleagues in as and when. I suppose What should I tackle first? So let's talk about the IT systems first. So we have seen what I would say is a very steady administrative numbers of whole-time equivalents and numbers of staff in primary care particularly. I think some of the digital functions that we're using in general practice is to help to release time for our clinicians, our healthcare professionals, to spend time with the patients that they need to spend the time with. So I would say that's stayed relatively static, but what we have done is almost transform that into them becoming more care navigators, and that is to then get patients to the right place at the right time with the right professional. From a GP whole-time equivalent perspective, I haven't got the numbers with me. What we have seen, particularly over the last year, is that we've got more trainee GPs coming into the local area. You may be aware that there is a national workforce plan, and what we have done is mapped locally what we want to do in terms of a local delivery plan that aligns with the train, retain and reform elements. So actually, what do we need to do to get more people trained to want to be GPs or wider healthcare professionals in general practice? How do we then retain them in our local area? And then what are the other key things that we need to do to make people feel like they want to work within the NHS and within the wider primary care? And there is lots of work, there is lots of key things that are going on within that kind of, within that workforce area that is helping to get more people into the local area and working within primary care more broadly. And what I would say is that yes, we are looking at things like, and I'm sure Mark will want to add to some of this, we are looking at career plans. So, you know, where a GP might want to be a GP for half the time, but actually be a specialist in that other half of the time. So how do we work with our clinicians to, I suppose, give them variety within their roles and help to retain them from that perspective? Mark, do you want to add anything more to that before I move on to that kind of education piece?
I think with general practice and GPs, there's a number of factors going on. We actually are in the middle of a employment crisis with general practice. There are GPs out there that actually can't get jobs, and that's why there's an addition of a GP role within the additional roles reimbursement scheme. So there are GPs out there, and I don't know the numbers within Staffordshire, but there are those that are unable to find those work. I agree with Tracy, there is full-time general practice is a very difficult role to have, and there's an increasing levels of burnout, and therefore GPs are looking for that variation in their sort of portfolio of work. So it's important that they work, you know, potentially look at sort of full-time work, but it might not necessarily be within general practice. It may be other additional roles that they carry out within the NHS. And I can give various examples of that even with myself, because I do a couple of sessions of research work with one of our local community trusts, which also has an impact, obviously, within the NHS.
Thank you, Mark. So just to then come back, I think you make a really key point actually in terms of that education piece. So for example, we know that some of the work that's happening, for example, in schools around dental and helping children to brush their teeth, that's going back into those children's homes and that's educating the parents. So we know that kind of approach does work, and that is something that we really do need to look at. And, you know, as part of the 10-year plan, that there's that approach, isn't there, around sickness to prevention. There is a lot of work happening internally at the moment, and maybe that's something that you may want to hear more about in a future meeting, around what does that prevention and that self-care piece look like. But it absolutely needs a really good education piece and communications wrapped around that to help our patients to understand how to navigate health services, but also how to help themselves as well. Pharmacy, so you will see within the paper that we've talked a little bit about pharmacy. I think there is a recognition that there is some recruitment and retention challenges broadly across primary care, not just in pharmacy. I think the impact on pharmacy has been where PCNs or primary care networks have been able to employ clinical pharmacists, and that maybe has shifted some of the workload out of pharmacy into primary care networks. What we do have is a robust locum workforce for pharmacy that can be called on to help in terms of if there are recruitment and retention issues. And also we're doing a bit of work around that kind of future planning and making sure that our kind of next generation of community pharmacists are supported with existing pharmacists and prescribers. I think the access plan very much focuses actually on how general practice and pharmacies work together. So again, it's creating that kind of primary care, we're in it together approach. What I would say is, in terms of Pharmacy First, what we're hearing is there is more scope actually for pharmacists to do more. So we need to listen to that and hear that actually, and work with our community pharmacists on what some of those opportunities are. And again, in line with the 10-year plan around hospital to community approaches. But just to go back to the point that you were making around viability of pharmacies. So yes, there is recruitment and retention issues across primary care more broadly. What we have seen locally actually is, and I've just got some numbers here, that we've seen 1 community pharmacy closure and 3 100-hour pharmacy closures in 2023, and then we've had 1 community pharmacy closure last year in 2024. So we hear a lot that's happening nationally in terms of lots of pharmacy closures. We actually haven't seen that more locally. And we're also aware that via the local authorities and their health and wellbeing boards, there's actually a refresh of the pharmaceutical needs assessment happening at the moment, and they will be coming out to engage on that, and we're expecting that approximately October time. And what that looks at is where there are potentially gaps in provision for then the commissioners to have a look at where those gaps in provisions are ready for the future. So there is, what I would say is there's lots of work happening around pharmacy at the moment, but we haven't necessarily seen what we're hearing from a national perspective happening more locally. And then the Joy app, I think that's a really interesting piece actually that's been happening in East Staffordshire. And what we do have locally is a PCN collaborative, so that brings together all of our PCN clinical directors, such as Mark, to come and share some of the approaches that they're doing within their local PCNs, to share that with others. I think one of the points that we made is we can't force people to do that, but what we can do is encourage and share that learning. So we do have an approach to doing that. And actually, we were really fortunate to share some of that work with Dr. Claire Fuller herself, who obviously works for NHS England, to share some of that approach. It's really good stuff. So again, it's how we share some of that learning. Mark, I don't know if you know the answer to question 1 around the investigations piece, hospital versus GPs.
I think with general practice and investigations, I think there's a significant number of referrals from general practice into these investigations, and there is obviously a demand which outstrips the capacity for these tests. I think hopefully that will improve. There's the development of the clinical diagnostic hubs, and we're seeing those being developed within the regions. That should give greater scope for actually patients. It's whether delay, it's obviously at what point you feel that the delay is. Obviously, a lot of the time it's the delay of actually getting into the physical examination itself and then the results coming back. Again, it's the capacity of general practice to be able to review those results and then get patients back in for those results. Again, it's obviously with hospital care, the element there is obviously it's the length of time for referrals. So GPs are doing much more investigations themselves, and those diagnostic hubs will facilitate that. Obviously, that will drive an increase in capacity and demand within general practice to review those results, and that's where we'll need to look at obviously the workforce around that and that impact. There's always consequences to change, and obviously those increased investigations that will occur within general practice.
I hear what you say, and I understand the demands, etc., but I've had a recent experience where I went for an investigation, and when I said, do you know what the result is? Oh, well, you were a GP referral, we can't tell you. I then waited 5 weeks. Not very good, I don't think.
No, it's obviously where we need to obviously can't comment on the individual cases, but obviously if there is those delays, and that's something that we need to be aware of and take forward.
In all honesty, I feel sorry for GPs because my GP feels that they're being, you know, treated like second class. As she said, I'm sure they think we don't understand, we're not bright enough. So, you know, I have sympathy with GPs in the fact that they feel they're being discriminated against because of the way the system has always worked. I'm not criticising GPs, I'm criticising the other end of the service.
Okay, I think that's something you might wish to take back, and I think probably without going into too much, I wouldn't be surprised that we've all got examples of that kind of thing. I know I have, but I don't want to necessarily go into it, but I think there is an issue there that probably does need seriously looking at. Councillor Steve Norman.
Yes, thank you, Chair. Apologies, two apologies. The first one is for being a little bit late there. And the second one is to apologise for being here all the future meetings because my colleague Leona Long is on the Health and Wellbeing Board. It was decided that I should be here, although she couldn't have been here actually because of a family emergency had she been still there. The second thing is to say, yeah, I just weren't sure what was being said about Tony Blair. I was ready to defend him, but that's okay. But just to let Councillor Jessel know that I quote John Selwyn Gummer, Lord Deben, on a regular basis. And the only Act of Parliament I have in my house, printed copy, is the 1990 Environmental Protection Act. And I can't say enough about John Selwyn Gummer. So there you are, we're all balanced there now. I haven't got anything profound to ask, really. I did note that there was, in paragraph 6 and 7, that there are 6 million appointments last year, which I think, if that was public, that might wake people up as to the work that's involved and the services are given by GP practices. I couldn't understand why my wife, I'm here because of the NHS, fortunately, when I want to order prescription, repeat prescription, that's easy, click on a few things and that's it. They did go over to the NHS app later, which is not quite so friendly, but still that was easy. My wife used to have to go down every now and again to the surgery, park up and all that nonsense. She doesn't know. I checked with her yesterday and she doesn't now, so obviously that's another great thing they're all coming on board. So nothing profound to say, except that I did wonder about when people do contact the GP surgeries and that actually are pointed in direction, not for that particular thing, but just generally about prevention and so on. I did note you said help themselves as well, so, but I just wonder if that was enough, whether you're being ambitious enough in that to get rid of, to try and reduce some of that pressure. And whether the timetable, this is a cruel question, are you ambitious enough and you're moving things along and getting things going or not? I mean, that's a nasty question. Really. I mean, you can refuse to answer it, really, to you, Chair.
I mean, I would say yes, wouldn't I? I would never say no. So yes, we are ambitious. I think, so there's a whole programme of work that's happening around prevention at the moment, and primary care absolutely needs to link in with that prevention piece, because if you look at the flow of patients, you know, we need to get those basics right, stop people from falling into the what's the analogy around falling into the stream. We need to pick them up earlier on in that process. So what I would say is yes, absolutely. And a lot of the work that the primary care networks are doing is actually aligned to some of that prevention piece. It's about, you know, getting the screening rates up. It's the vaccine and immunisations that Sam is going to be talking about. So there is, there is a really great ambition actually in terms of some of that work in primary care. I don't know if Mark, you want to add some of that as a CD.
Yes, I mean, I think ultimately we need to be reducing demand, and it goes back to our previous councillor's question around sort of prevention. Prevention is an absolute must, and all parts of the system need to be working together to reduce illness within the things. We need to pivot the NHS to be much more preventative than obviously around the disease element. If we look at some of the instances of some cardiovascular disease by 2030 will increase by approximately, off the top of my head, by about 20%. So we need to be looking at how we can prevent that. How can we get people to reduce their cholesterol, exercise, reduce their weight? They are absolutely key factors, and we've got a wide-ranging programs, obviously within the NHS, of the core 20+5, looking at reducing those inequalities, looking at those barriers. increasing screening. So around some of the behavioural change work that's been going on, it's been how we can look at encouraging people to take up those offers around cervical screening, around bowel cancer screening, which are absolutely must, because if we can get people in early, obviously we improve survival rates and we then reduce their demand later as, you know, as their illness progress on the NHS. So very much so that I think we've got a programme moving forward. I think in anything like prevention, we need to ratchet that up even more than we are doing at the moment, and hopefully we can see the dividends. The difficulty is it takes 5-10 years for that, you know, for that data to come through that we're winning on that prevention front.
Councillor Charlotte Atkins.
Thank you, Chair. I appreciate there were a large number of professionals within the GP surgery, but there will be people who want to see a GP. And I don't know about other GP practices, but normally it would be a 2-week wait. Do you have what you consider to be an acceptable period of waiting? Do you have a target? Because it seems to me that most people would regard 2 weeks as being too long. And all it does, it drives people into A&E, because they can be, or indeed, if they're lucky, into a walk-in centre. So that's the first question. Second question is, you talk a lot about pharmacy first, and of course that's absolutely right. But what are you doing about those areas, like my own town of Leek, where there is no out-of-hours pharmacy, and there hasn't been for a couple of years? So what does that do? That drives people into A&E. And again, you were talking about joined up professionals, people working within primary care. My local PCN have asked the ICB if they can run the minor injuries unit. And of course, money must flow with that service. And of course, it's not happening because the ICB are not fulfilling or are not facilitating that. And given the uncertainty of the Leek MIU, despite all the general assurances about we have no plans at the moment to close it, we all know that there are plans to close it, because otherwise why would you have 2 consultation meetings in Leek about the closure? So why aren't you enabling local GPs to expand their horizons by looking at running something like the local MIU?
Okay, so again, I'll bring Mark in because I'm sure he'll want to comment a little bit about the first question, which was around seeing a GP. And I think, I mean, this is why it's really key, isn't it, that we do have this broader skill mix in general practice to get patients to the right place at the right time with the right professional. So actually, you're absolutely, I mean, we do have variation. So, you know, we have 142 practices. There is variation across those practices in terms of their access, and that was one of the things that I did begin with in terms of we really, you know, need to understand that and home in on some of that. But actually, if we release some of that time with our GPs and get the patients maybe thinking differently or navigated differently, that should release the time for patients to be seen quicker by their GP. So I don't know, Mark, if you want to add to that.
I mean, I think we should be seeing the two week as a minimum. That's to ensure that people get in. But Tracy's right, and some of the things that she was saying is that what we're trying to do is, if we can release capacity, we look at being able to be seen on the same day. We're trying to look at the skill mix around that. So we've got a lot of practices have now got urgent care practitioners, physicians associates to try and deal with that on the day, same day, emergency care, releasing GPs. So it's important how we try and use that skill mix to the best we can, and we've got to try and get patients to understand how we're changing and be able to use that system to know what clinicians in each doing, so we can free those clinicians up to reduce the time and waits that we've got. So everybody wants to see a GP, but nobody's seeing these other staff. These other staff are sitting there not doing anything. They have a role to play, and it's how we use that sort of that increased sort of multidisciplinary team effectively to, as a team, to ensure the patient care. So it's not only just seeing the GP. All these members of staff are being supervised by GPs such as myself. So it's part of that extended team and we work together for patient care.
Quickly come back on that, because, you know, when you ring up your GP, at least if I were to ring up my GP, and you talk about the telephony and how it's moved on, etc., etc. So you get the message, well, you know, you can get an appointment at 8 o'clock in the morning, and we're presently waiting on sort of 2 weeks. He doesn't say, but, by the way, you could see, you know, the practice nurse, or you could see the physiotherapist. It doesn't say that. So the average person, or at least the person who very rarely goes to the GP, will think that's the option. So why aren't you doing more to say, you know, these are the people that we have available, you know, the nutritionist, the practice nurse, or whatever. And then there's a choice. But no, the choice is, you know, if you want a prescription, yes, we won't do that on the phone, understandably. But there's a 2-week wait. And by the way, 8 o'clock is the time when you've got to ring up. And so you sit on the phone for, I don't know, half an hour, whatever. I don't know, I've never done it. But, you know, you wait for half an hour for the phone to be answered.
There's a programme of work around that. I say it's not perfect at the moment, but we are looking at trying to educate, and that's part of this sort of behavioural change work that we're trying to induce. So there's been some very small pilots of that work going out into practice. My practice was one of those that demonstrated the effectiveness of this work on how we try and demonstrate the different sort of skill mix and different clinicians. The difficulty is around PCNs, that each PCN and practices have different workforce. Obviously that needs to be tailored to that individual, that message needs to be tailored to the individual sort of practice and PCNs, but that behavioural change work is being extended across initially 8 PCNs to help and support that education around the different clinicians that those practices have, and moving that work forward. It's not perfect, but I think it's work that's underway that's trying to improve that education across the region around the different workforce that's now existing in general practice.
I also think patients won't listen to us from an ICB, so we can put all of our communications out. Patients listen to their general practice, they listen to their GPs, they go into their practice and they hear those messages. What we need to be encouraging more is actually our GPs and our general practices more broadly to build the confidence in those other workforce, that broader skill mix, because that's where the messages are really going to help. So I think it's building on the work that we're kind of already doing, but I absolutely do take your point that there is more work to do within that comms behavioural change and kind of, that whole piece really. In terms of pharmacies, so I think you may have heard me say around the pharmaceutical needs assessment. So that's happening at the moment. What we want to do is to receive that pharmaceutical needs assessment. I do believe it's going to be before October, where that will help and guide us as commissioners then to look at where are the gaps in terms of our local area and respond to those gaps. And then just in terms of your final comment, I'm not sure I can comment too much on that because I haven't been too close to some of that work. But what I would say is there is a real ambition in general practice around that hospital to community piece. And there is some work that's happening at the moment around community transformation. So where are the opportunities in primary care and more broadly within our community services to do more in the community? But I think that's all I can comment on in terms of that.
Okay, just to come back on the pharmacy point, you know, Leek has been without an out-of-hours pharmacy for about 2 years, something like that. We don't need a pharmaceutical needs assessment to tell us we need one. You know, the ICB comes to the local community, we go through a tick box exercise, oh, go to pharmacy first, go to pharmacy first. Fine, they don't even know that Leek, for instance, doesn't have an out-of-hours pharmacy. We don't need that assessment. We don't need to wait until October for that assessment. We know that there's a gap already. The ICB is the commissioning body. You know, understand what's happening on the ground now rather than what you want to be told in October. So we wait another year to sort it out. Sort it out now.
We are aware in terms of the closure of the pharmacy in Leek. We are, as I say, as ICBs, we're very much driven by the pharmaceutical needs assessment and what that tells us, and local authorities are informed of any closures of pharmacies, and to date we haven't received any further information in terms of whether that is a significant gap to enable us to then look at whether we need to commission something for the future. So I absolutely take your point. We are aware of it. It's certainly on our radar, and we are working, as I say, with local authority colleagues in terms of that pharmaceutical needs assessment. Thank you.
I think Councillor Atkins, in terms, makes a very valid point, not probably just for Leek, but obviously when there isn't a pharmacy, what are we supposed to do? And just on the pharmacy situation, I've noted, again from prescriptions that I collect, taking a lot longer to come through to the pharmacy itself from the GP. Now, it may be that the GP has acknowledged it, and this new system, you get a text to say, we've got your prescription. But you then wait nearly another week. Well, sometimes that prescription is being given to you for immediate response, and it seems the pharmacy doesn't necessarily pick that up as quickly as it perhaps should. Yeah. Councillor John Jones.
Thank you, Chair. I'd just like to endorse everything Councillor Atkins said about the pharmacy in Leek, and particularly about the Leek MIU. Most of what I wanted to ask about has been covered, but I'll just make a couple of comments on the results, getting results back. Why it takes 2 weeks in this day and age, if I go for an X-ray, to get the result back to the GP seems bizarre to me. I mean, apart from, again, at Leek, where the X-ray machine is so old, I think the instructions are in Latin. Most X-ray machines now are digital, and the results, you know, there's no film involved. It's where you go. So, and I think sometimes that's a bit of a legacy attitude from the GPs, like it is with the banks on 3-day clearing on a cheque. You know, there's no need for it anymore. So I just wondered about, you know, I'll just make that comment really. I just don't understand why. Good to hear what you said about more GPs coming along, but it's needed, and I think the number of GPs that appear to be on the books is probably misleading, because a lot of them are part-time now. I know the 2 of them at my practice, they only do like 2 afternoons a week. That said, my practice is pretty good on, and I think what you said about you can tell them what to do, but they've got to do it, is a valid point. At my practice, I know I can go on the app, and I can book a nurse online. You know, I've got to go through the mill for a GP, but I can book a nurse online. And again, with the first contact physio stuff for bad knees and lips and stuff, I had a misfortune. I had to have a knee replaced at the middle of last year, and I went in October to see the GP. I was referred to physio. I went to X-ray straight away. 2 weeks wait for the X-ray because I went to Leek, bad choice. So the physio in November, surgeon in December, I had the procedure in the March. A friend of mine went through a similar cycle this last year, identified the problem in October. She's still waiting for a physio appointment in February, because the GP just went, oh, that's physio, off you go. So I think sometimes we've got to work, you know, it is down to making them, or persuading them to do what you want them to do, really. And it is, you know, they're autonomous, aren't they? Not much you can do about it. The report talks a lot about pharmacy first. I think it's great, but the problem with pharmacy first is that invariably when you go into a pharmacy, there's half a dozen people waiting to be served, particularly in a community pharmacy where the sort of retail side and the pharmacy are pretty much merged. And I worry about privacy. And I know they've all got consulting rooms, but if a pharmacy is busy, you know, they've got half a dozen people to serve and they've only got 1 assistant. I've heard it a couple of times, conditions are being discussed across the counter. So I think that's something that just needs to be perhaps just considered. And the only other thing I wanted to say was digital access. It's great doing all this digital stuff, but we've still got a legacy demographic, probably for another 20 years, of people that haven't got a clue about how to work a mobile phone or a computer. And I notice in South Staffs that's been addressed with the team to sort of look at that and see what can be done. Is that going to be rolled out elsewhere? And And I think that's it, really. Thank you very much for the report, and thanks for coming.
I mean, I'll just come back about sort of 2 points that you made. I think the results thing is obviously is an important thing to take away. With the results, particularly our x-rays, as GPs, we don't see the actual films, we just see the report. So it's a matter of time for that report to come through, then be commented on. My understanding is, as similar to your blood results, your chest x-ray results should be available on your NHS app once I've commented on it. So hopefully, that should hopefully speed up the process. Obviously, your interpretation of what that then means for you as a patient, if I've written a comment on it, is obviously how that then fits into your care, which then needs another sort of contact with a clinician, being possibly a GP at that time. Moving on from that, obviously the comments about the NHS app is obviously we don't want to introduce this sort of digital inequality as a consequence. It's the unintended consequence of sort of moving in that direction, and there's obviously a programme around trying to reduce that, make sure that inequality is not impacting unduly, but also making sure that the traditional ways are still open for those people to be able to access care.
If I may, Chair, I don't think I switched my microphone on last time, apologies. I always understood that radiographers, their protocol was not to tell you, that it was, they wouldn't comment. They would always say, you need to see the doctor. And I think that's right, because I think otherwise people get the wrong idea of what's going on and not going on. Am I correct in that?
Yeah, so the radiographer won't interpret and they will make sure the pictures, as it were, the x-rays are of good quality for the radiologist or the person that's then subsequently reporting that film is of good quality to obviously give an accurate result. That result in it, obviously its report is then sent over to the clinician that requested the report, be it the GP or the advanced nurse practitioner, for them to then comment on, which will then be on your notes. That then should be available on your NHS app, if I'm understanding the process correctly. For you, that once that report is commented on, you should be able to then see that X-ray result, as you would do all your results and your other aspects of your notes, prospectively moving forward.
Yeah. Okay. Thank you very much.
Thank you, John. Now call Councillor Anne Edgeler.
Thank you very much, Chairman, and thank you very much for your presentation this morning. Yes, one or two of the questions that I wanted to ask actually have been asked. Councillor Jones just picked up about the elderly, and that was one thing that really concerned me, because a lot of people, like we say, haven't got computers. And I'm wondering if it's something the GP practices actually could have a list of the people that they know are very elderly and what have you, and that whether they'd be able to do a little bit of work to help them sort any problems out. So that was one thing. The second, about the mental health practitioners in general practice. Is there a mandatory thing that they should have a mental health practitioner in there? Or how many practices haven't got them, and are you working towards making sure that they do have them? That was the second thing. The third thing was you talked about dentistry and children, and I had the pleasure this morning of seeing my 1-year-old and 2-year-old grandchildren cleaning their teeth, but they're going to nursery. So I'm wondering, we talk about schools, but I think some of these play schools and what's happening, call them play schools, but nursery schools, some work could be done with, though, you know, going in there and picking up on that and getting children to clean the teeth. Where are we at with working with the patient participation group? Because I attend mine, but they always complain they don't get any feedback or anything from yourselves. So I'm just wondering, you know, what moving forward, how you can improve that situation, please. And I'll just compliment the pharmacy in my area. It's absolutely brilliant. But talking to the gentleman there, he was very concerned. I think Julie picked up on the point about getting paid for the work that they do, because they're picking. I've noticed this morning now they're doing injections for weight loss. And I'm thinking, what? You know, I think it's absolutely fantastic how we've moved forward. But like you say, it's getting people out there to know that the pharmacists are doing all these things. It's education, 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 isn't it? Yeah. So really, that's as much as I want to say, Chairman. Thank you.
You'll get Steve.
Thank you, and thank you for some positive feedback. Actually, that's really good to hear. So I think just to pick up the point again around, I don't think we can say that age is necessarily a barrier around digital, because I think, you know, we have really good examples. My mum is one of them who absolutely loves her NHS app, and I know many other people that do, but some people don't want to use that. So it's making sure that we aren't creating inequity. And there is some work that's going on actually at the moment around a kind of digital inclusion pilot, where we're specifically looking with some of our primary care networks at some of the things that we can help to put into place to minimise some of that. And there's work happening at the moment in terms of local libraries, maybe running sessions for people, because libraries are known as a really trusted place for people to go and get help and support. So they're going to run some sessions around the NHS app, for example. So I think this is an evolving piece. I don't just think it's relevant to the NHS. I think there's a whole piece nationally around digital anyway. Mental health practitioners, so there is a really strong link between general practice and our community mental health trusts in terms of employing mental health practitioners. I think all of our PCNs have got mental health practitioners from recollection, but I can certainly check that for you. It's a really key part of the workforce plans anyway. It's part of the additional role scheme. Dentistry in children, absolutely. I mean, the earlier the better, isn't it, in terms of that education piece. I think there is some work actually happening also in nurseries, so it's not just schools, but yeah, take your point. And patient participation groups, I think that is actually in the plan as well. From an ICB perspective, we do a lot of support with our practices and PCNs, because we have various PPGs at practice and PCN level. And we provide a lot of support working with our communications and engagement team. But again, I think that's for our GP practices and our PCNs to be. We don't run those. We absolutely contribute if we're asked to contribute to those. I don't know, Mark, do you want to add anything in terms of? They're so important, aren't they, to hear patient feedback? It's another way to gain that patient feedback. But I don't know if you want to add anything more.
No, I mean, I think the mental health practitioners are an absolute value and an absolute asset across the practices to help the difficulties in the mental health increase in instance that we're seeing across the region, really sort of post-COVID. And I wouldn't be without our mental health practitioners, and we've got 2 across our PCM. PPG groups, I think some practices have struggled with those, trying to get fair representation of the demographic of their practices. They're only it's an element of 2 factors. It's an element as good as citizens and those patients register with the practice wanting to give back to the practice to help support them as well as the practice. So it's a sort of two elements to that. And I think, you know, from our own practice, we've struggled to get people wanting to come forward to be in our PPG groups, because people are time poor with all their other commitments. But it's an invaluable asset to have that feedback on how we're performing as a practice, as a critical friend.
Can I come back, Chairman? Just a couple of thank you for that. Talking about the elderly again, what age do you put, and you talked about having tests for bowel cancer and what have you, what age limit do you put on that, and breast cancer? You know, because you get to a certain age and you can't have this done because you're over that. You know, so is there an age limit on that? And if there is, what is it? And if there is, what can we do about it? Because there's a lot of people are living now well over 100, you know, and it's something that we should be looking at. And the other thing I'd like to pick up on it, we look at on the number of PCNs and that, if I can be just talking about Stafford for a moment, quite short in numbers actually, and with the rising population in the area, what are we doing about that situation? Thank you.
With regards to screening, they're all part of national programmes, so we don't have any ability to sort of flex the age. So there's the breast cancer screening programme that starts at 50. I can't remember its cut-off age, so I won't guess and give you false information off the top of my head. The bowel cancer screening test, the FIT test, the stool test that people may have been aware about, that's actually slowly coming down, and that's because we're seeing a greater instance of bowel cancer in younger people as well. So that at the present, that's 55 moving down towards the age of 50. That does have a cut-off age, and I'm sorry, I can't remember that either off the top of my head, but we can find those out and give you that information back.
Thank you. I think Councillor Edge raises a very valid point with regards to a lot of our areas having the house build that we are getting, increasing populations. And obviously, I think for residents, I think it's important that the confidence of knowing they're going into an area is going to be covered by GP practices with that additional population, and obviously that extends to pharmacy availability as well. So we're obviously seeing, you know, not just Stafford, Lichfield and East Staffordshire. You know, you can go on. We're all experiencing it, and no doubt we're also going to have to experience more of it with the ambitions that are being presented of 1.5 million over the next period. So it needs obviously everything to be addressed to go along with that additional house build. So it's a very valid point. On my list next is Councillor Janice Sylvester-Hall.
Thank you, Chair. And just to finish off the previous sentence that you made, I would also add Burntwood onto that list as well, knowing that there's a lot of activity over there at the moment with regards to provision of care and also hopefully pharmacies too. My questions, I've tried to sort of theme, if that's okay, and some of them have been mentioned already, but I would just like to look at some of those in a little bit more detail. So in terms of the level of the access that we've got, consistency is my question across the piece with those. So whilst we don't necessarily have the same amount of pressure on the telephone system, because we can go and book on an app, how much is the consistency improving across the piece with those? And I think that they do complement each other, absolutely. So getting the balance on those, I think, will be extremely beneficial to those who are using the service. With regards to connectivity, is the next one. It's not just words with C that I'm picking, there are some others as well. How we make sure that we have that connectivity when we are working with pharmacies and they are doing some of those either blood pressure testing or how we make sure that we've got a reliable system of transferring that information. And again, I'm asking that knowing that when we sometimes release patients from hospital, it's only of late that we have that connectivity amongst different areas for those. You mentioned the training, the level of engagement with the training and how is that measured and reported. I'd like to know if that there was training being offered to my GP practice, that they're taking advantage of that in some way, and if not, why not? And then finally, if I may, health inequalities, and looking at the element of those, colleagues won't be surprised to know that I'll take the opportunity to mention the Women's Health Working Group that we established and the publication of the report that we had in October last year. There's a substantial amount of information that has been born out of that one with regards to health inequalities in particular. The one that we're focusing on or have been of late is endometriosis and looking at opportunities for partnership working, for diagnostic tools and also self-referral. And it's just considering what the opportunities that there could be therein with some of those. Thank you.
Shall I start us off, Mark? So I was pleased that there wasn't 4 C's because I was starting to run out and think. So from a consistency, I mean, there is going to be variation. I think that's probably what you're probably getting at, isn't it, in terms of that variation piece. And I have recognised that there is variation across, and what we want to do is to minimise that variation as much as possible. So the work that we do with our practices and through our pharmacies is about how we improve and minimise that variation very much so. So our eye is constantly on that. Connecting with pharmacy, so there is a working group actually that's been set up between pharmacy and general practice about kind of improving that working relationship, making sure that we do have that connectivity between our primary care functions, and I think Mark can probably talk a little bit more about that in terms of how that actually works in the background. Training, so again, we are going to have that variation in terms of uptake of training. We get that anyway. But as part of the PCN plan, so each PCN does have a plan around access, and I would imagine, and Vicky will correct me if I'm wrong, that all of our PCNs will have that element of care navigation training within their plans. It's really important. And the health inequalities, again, really recognise there is opportunity around some of that, particularly around the women's health hubs piece. So I think, again, practices and PCNs do have a role to play in some of that, and we're very much working closely with some of our commissioning colleagues around how we make some of that happen. But I'll bring in Mark, because I'm sure there's bits that you want to just pick up on as well.
I mean, consistency is vital, but there's also an element of variability, which is also good as well, because obviously it's allowing you to have a variation of your practice if you've got a unique or different population, which is important. But all practices need to be providing a sort of consistent basic level of service to everybody. And they're obviously doing that through various sort of incentive schemes. There's some already in place, such as the QOF, which is the GMS, which is the national contract the GPs have. We've also got some local incentive schemes around that as well to help that. So we've got a sort of a QIF system, which is trying to reduce some of those health inequalities so everybody gets a standard service, and also something called the universal offer, which is around ensuring that GPs provide a set sort of level of service to its registered population. With regards pharmacy, I think it's an area that's an absolute must. It's about how safely patients' information post-discharge and other activity is shared with those professionals involved in their care. I think there's still a lot of work to do. There's sort of discussions, obviously, when patients' medication change post-discharge, how that information is also shared with the pharmacy as well as their GP practice, because at the moment it's not readily shared with their pharmacy. So there always the risk of medication error. So I think it's a real important aspect that data is shared, and is shared between sort of everybody providing that care across organisations. I think it's work in progress.
A quick follow-up question on those then. Is there any sort of idea of a time frame available with some of those developments in the working groups, specifically on the connectivity, that you're able to share with us?
I was just going to say, I mean, this work is happening at the moment. If you wanted solid timescales, we can certainly have a look at getting pull out some key points in terms of some of that. I mean, I don't know if you want to add anything, Vicky, because I know you're a bit closer to some of that pharmacy and GP connectivity piece. You okay with that?
Yep. I mean, in terms of the pharmacy and GP connectivity, it is an ongoing piece of work, because there's new elements that are coming down from a national perspective. So a lot of, like, the Pharmacy First are very much driven from a national. It was a national push in terms of moving that activity from general practice into pharmacies. So a lot of this is very much ongoing as these pharmacies come online, because nationally we haven't got 100% coverage from those particular pharmacies. So we see this as an ongoing piece of work because of the role that pharmacy has within our local communities, and it will be very much part of the community transformation and the building of integrated neighbourhood teams as well. So it's very important that we have that ongoing dialogue with them. So in terms of timelines, it's very much as soon as possible, but it's going to be ongoing because they are very much part of our health service landscape, and we need to make sure that they are involved and integrated as part of that piece of work. But we have got very much local working groups. We work very closely with the local pharmaceutical committee, who have those links into local pharmacies as well, to make sure that all voices are heard. And we also talk at a regional level when we are encountering barriers at a local level, that we may need some regional support to move on and have some of those national conversations on our behalf as well. Mm-hmm.
Yeah, and if there are, if we could take you up on the offer, if there are some milestones on there or some dates, that would be beneficial, I think, Chair. Thank you.
I'd like to call now Councillor Bernard Peters.
Thank you, Chair. Just a couple of points, if I may. In the context of East Staffordshire, where I'm based, Could you tell me or give me some assurance that the reach that you have is getting to people where English isn't their first language? And how do you know that the message, they may be hearing it, but do they understand it? How can you assure yourself on that? And another point I'd just like some assurance on is safeguarding. There's been some new standards, I think, or some recent guidelines issued in terms of the responsibilities in GP surgeries for safeguarding. Could you just play back to me how you're addressing ensuring compliance with safeguarding related issues, please? Thank you.
Thank you. So in terms of English not being the first language, I mean, I think this is a problem that we do have in general around our communications strategies sometimes. There is a project that we're about to embark on locally around health literacy, because we are very aware that average reading ages are decreasing within some of our local populations and in some of our communities. So some of the work that we want to do, and primary care is going to be a key element of this, is actually how do we reach out and make sure that we're reaching out and helping our communities to understand the literature that we're putting out there, the communications, and how we get people to engage as well. So I think your point is really well made, and we're certainly very much aware of that, and we're hoping that actually we're going to be able to get this project up and running quite quickly, because I think it is really important, not just in East Staffordshire, but broadly across Staffordshire and Stoke-on-Trent as well. In terms of safeguarding standards, I mean, what I will say is I'm not a clinician. However, clearly our GP practices do follow our safeguarding standards. They are assessed on this as part of their CQC ongoing kind of registration approaches, etc. But Mark, I don't know if you want to add anything further to that specifically. I'm not sure I can necessarily answer any more than that.
I mean, safeguarding is a dramatically important aspect. We're seeing much more increase in demand for sort of safeguarding referrals in general practice. I'm not aware of any change in safeguarding guidance, but it's obviously it's a significant part of our day-to-day work, and it's an important aspect that GPs have suitable and sufficient training, and across all the clinical staff from that point of view. We've got named safeguarding leads across the region for support as well.
Yeah, and we do also have local safeguarding leads as well that support general practice and deliver some of that training on the ground to our staff as well.
Would it be the practice manager's responsibility to ensure that each GP has had the training, or is it left up to the GP to make his own arrangements?
As part of revalidation for GPs, you have your own sort of professional responsibility to ensure that you've got sufficient safeguarding training. It used to be that you had to have a certified number of required hours. That has subsequently changed to ensure that you have undertaken sufficient training on your own professional aspects of the needs that you undertake. So there's an individual responsibility as a clinician, which is picked up at part of your revalidation. As from a practice perspective, obviously the practice manager would oversee that clinicians have had that training, but ultimately be responsible to the GP partners that run the organisation.
Okay, I've got Councillor Anne Edgeler and then Councillor Kath Parry. Anne, over to you.
Thank you very much, Chairman. And again, what is the ICB doing to become get more people becoming dementia friendly? You know, it's one of the biggest killers, I understand, if I believe everything I read, in the country. So what is the ICB doing to help with that problem? And the other question I've got, and it was an email I received the other day from a lady, she'd had some crutches from the hospital, she'd had a knee operation, and she didn't really need them, so she took them back to the hospital, and they said, oh no, we can't use them, they need binning, they're no good to anybody. So what can be done to eliminate this problem? We're wasting a lot of money on equipment that's loaned out to people and you know, not take, well, they take it back, but they don't want it. So I'm just wondering how you can save money on that situation. Thank you.
I wish I'd got the numbers around dementia friendly, because actually we've had a lot of our practices that are now dementia friendly practices. So I will obtain the numbers and I will provide that to you after today, because we did some work. Mark mentioned the quality improvement framework. There are initiatives where we support general practice in particular areas. And one of the areas that we did last year was around being dementia friendly practices, veteran friendly practices. So we've started to see those numbers increase, and as as we learn from those, the learning is cascaded out to other practices who also want to come on board as well. So I would say it's very much core and central to some of the things that we're doing at the moment as part of this plan, but I will get those numbers for you. I'm not sure I can answer the question around the waste, actually. I'm not sure, Mark. Is that something?
Is it more around medication wastage are you referring to? I mean, it's obviously important that we don't want any wastage. We haven't got enough money to waste from that point of view. It's difficult to advise around obviously crutches and other equipment, because most of those don't probably come out from general practice. I mean, one of the key bits that I can comment on is around medication wastage, which is really a significant cost as well. Is that when medications are distributed and they're no longer required, because obviously they don't know how they've been stored. It's unsafe for them to be reused. So unfortunately, they are destroyed. With sort of crutches and other equipment, I think it's obviously important that we take that back and look at it with our hospital colleagues.
Thank you. I had mentioned this in full council regards a charity called Grace Cares, actually based in the Lichfield district and actually in my county division, and they are doing an extremely great job at the recycling of the equipment that Anne is referring, and they're getting obviously more well known across the county as well, and further afield. So it's a wonderful charity. Grace Cares, they're absolutely marvellous. I've now, if I could ask Kath Perry.
Thank you, Chairman, and thank you for the report and answering the questions you've answered. I'm not sure mine's a question or there's a question in there. Obviously, there are still some challenges in the report, and I'm sure you'll do your best to overcome those. One size certainly doesn't fit all at the moment. There's lots of differentials across the county. I'm South Staffs, and so you've probably got the information from, well, you have, because it's in the report. During this transformation and empowering people that we've been talking about, I'm just hopeful that we're an expanding population, as has been said, with new build. We're also an ageing population. I'm just hoping that in this process, people don't get missed. And that's very important, that there's no patient that gets missed for one reason or another because they can't access or whatever the case might be. So I wish you all the best with this. Like I said, I don't think there's a question. It's more of a sort of comment, really. And it'll be interesting to see how it progresses. Because every time you seem to go to the GP, there's something different, or the pharmacy, there's something different on offer or something changing. So it's getting your head round all of those changes that are in there. So that's it, Chairman. Thank you.
Thank you. And that's the bit that we want to, it's really hard to measure, isn't it? But actually we want patients to be feeling the difference here. We want them to be experiencing the difference. So we will be very much looking closely at the GP patient survey that's out at the moment when we get those results. But thank you for your comments, and we would love to come back and talk to you a bit more about this as this progresses. Just to also add, we have 88 practices that are now dementia-friendly practices, which we think is quite significant, and we want to continue, and our ambition is to increase that and have all of our practices dementia friendly. So I just thought I'd add that.
I've now got 2 more speakers, and then we'll probably round it off then. Councillor Phil Atkins.
Yeah, it's there's a bit about language came up earlier on, and I was, about Latin, lignum crucibus arborsci entiae. So I think we, I adopt a Christian attitude to this, because that means the wood of the cross is the tree of knowledge, and I'm going to use a bit of French now, déjà vu. I always go and look at the executive summary, the conclusions, and then the appendices in any report. And it is really déjà vu, because somebody asked me about the evidence about two-tier and unitary, and I referred them back to the 2010 report that this council gave to the House of Commons about, it's more about partnership working and working together. And there was a thing called the Blake Project, which is down in the south of the county, where we did some work which found out the amount of money that was being spent in that area was considerably more. It was about £3,000 plus per head, as opposed to the average, which was about 360, because that was where the need was. So we've had questions about GP surgeries, pharmacies, and if you get into the appendices, there's one useful map about GP practices, which is scattered around the county. There's another on page 44 of your report, 62 in the document, and there's also something about the health inequalities on pages 46 of the report, or 64 in our report, and then the super output areas, which is the following page. And we're just missing that bit about pharmacies, if that's the other gateway into the health service, or trying to prevent them to get into the health service. Some of it makes pretty depressing reading, actually, Chairman, about the differences in your life across the county, the age that you will die at, the amount of years that you will have in poor health at the end of it. It's quite striking. But the super output areas, I'd like to see, and I think it is there, but it's not quite plain, that where the need is, there is something for people to go to. But then you end up with this rural sparsity issue, because it will put GP surgeries in Stoke-on-Trent, Burton, Cannock, because that's where the ill health is, that's where they're going to have shorter lives, that's where they're going to have more life where they haven't got things. But that doesn't mean the other areas where they've probably got a better chance of health in life, we need to help them as well. And the needs, I'm not going to get into your working out, because I get to the conclusion and the evidence and see how you end up with one. But I think there's quite a bit in that, because I represent a rural area, and it doesn't matter how you go, there's no bus service to get to a pharmacy or a GP surgery. So there needs to be another solution, and that could be delivery. I took the point up about what do you do with waste on drugs. That's one thing, and waste on household aids and adaptations. And there is a very interesting conversation, I think I'll use the word, about how you help people out in the community, because then you get the mileage and everything else, and you've got to persuade them to go to somewhere more central where they can be helped. But it's a really difficult one, and I haven't got the solution. I'm not paid enough, actually, Chairman, to work it out, but and I've got other things to do. But I think there's a little bit about the pharmacies and where they are, and then and then showing that you're serving the need of whatever it is in that particular area, remembering that just because somewhere they're healthy and they're in the middle of nowhere, they also need help at some occasion.
I mean, I think what you're saying there is it's the pharmaceutical needs assessment that will absolutely map out our local area against provision. So I think that's probably the answer to your question.
Okay, Chairman of Council, Councillor Phil Hewitt, welcome.
Oh, thank you. My apologies.
Thank you for your representation this morning.
Thank you. You are aware that I attended another event before this, so and I wouldn't normally interrupt when I haven't heard all the details, but it was just one very simple point, Mr. Chair, Councillor Anne Edgeler, where she said they didn't want the equipment back. I think sometimes there has to be a balance on that. I broke my leg and it hurts a couple of 3 years ago, and they all the equipment returned, and they had real joy at taking it back. I popped it to Lichfield, to the hospital there, and so I think there's a balance sometimes. I'm not saying that what Anne said is wrong. My experience was very different, that I took my crutches back and they were absolutely delighted to have them back. So I just wanted to put a balance on that. Thank you, Chair.
Thanks you, Councillor Hewitt. I think just before we round off, there's one question I had got. Has there been any impact as a result of the collective action from GPs?
So we do have a, for want of a better word, a task and a finish group around the collective action piece, where we have providers and general practice. So we have LMC representation at that meeting to look at any potential impact. What I would say is that the actions that general practice have been taking at the moment is more around data sharing agreements. We haven't seen any particular impact on appointment levels, but that is something that we are monitoring really closely.
Thank you for that. Sorry. No, thank you for that. So regards then this item on the agenda, it's for us to note. Are we okay with that? I know that we've got not any particular actions to bring back, other than obviously perhaps in a period of time a new committee after the elections may wish to obviously see you again and get another update on it, because I think it's something that we ought to be certainly monitoring rather than not seeing you again. And thank you for today's participation. I hope a good hour plus there hasn't been too daunting for you, but I think it shows that in terms of representative of the communities that we represent, there are concerns out there. I think there's been a broad range of questioning that has come that collectively, obviously, we've got to, in a sense, I suppose the word I'm looking for is we've got to keep you on your toes to ensure the service is delivered. Very difficult to manage expectations, but I think without, obviously, this committee, we've got to make sure that you're, as I say, you're kept on your toes. So thank you very much for your presence. Thank you. So, moving on then to item 5, which the Staffordshire Stoke-on-Trent ICB, a vaccination update. Samantha Buckingham, so welcome. If you could give us your report, that would be very good, and then we'll take questions from councillors. Thank you.
Lovely. Well, thank you for inviting me. My name is Samantha Buckingham and I'm representing the ICB. So I'm the Head of Clinical Business and I lead on the vaccination and immunisation programmes. This is the first time we've reported on vaccination and IMS at this committee, as far as I'm aware, from either the ICB or previously the CCG. And the reason for this is because we didn't formally have a role from an NHS perspective on vaccination and immunisation programmes. They are very much commissioned by NHS England. They are routinely commissioned by the NHS England regional teams, but they are all national schemes that are obviously applicable across the whole country. Prior to COVID vaccinations, the only role that the ICBs and the CCGs had previously was to support our local providers, and this was primarily our general practice providers and things like the seasonal flu and the 0 to 5-year-old vaccinations. They were the key things that we supported our providers to do. COVID vaccinations changed that. So you were all aware in December 2020, obviously COVID vaccinations were brought in, and there was a massive programme of work across the country to obviously get as many people vaccinated as quickly as possible. That gave, I think it was CCGs at the time, just before ICBs were actually formed, that gave a very clear remit for CCGs and then ICBs to be involved in the design of those COVID vaccination services. And from there, we've been able to obviously get more involved in all the vaccination services, working very closely with NHS England and also very closely with our public health colleagues in the local authorities. We're now very much working as a system, and we have key stakeholders across our Staffordshire and Stoke-on-Trent. We have regular meetings with our local authority colleagues, and we work very closely with NHS England. And that's very important because as of April 2026, the commissioning responsibility for vaccination and immunisation will move from NHS England to the ICBs. So we obviously need to work over the next 12 to 18 months to make sure that we've got the right governance in place and the right operating frameworks in place to be able to deliver our key delegated responsibilities. We are starting to build those governance structures, and they will be in shadow form from April 2025, working alongside NHS England to make sure that we obviously have a really effective vaccination programme to deliver for our local population. Current achievement on vaccinations is detailed in the report on the 4 key main areas that we've been supporting over the last 12 to 18 months. In general, we achieve quite good uptake in vaccination and immunisation across Staffordshire and Stoke-on-Trent. We are benchmarked within the NHS at an ICB level, so the majority of the data within that report is at an ICB level, but we do recognise that as we go through the next 12 months, we do need to look at that breakdown of data to get a more granular perspective across all the local authority areas and boroughs, etc., to make sure that obviously we're reporting the relevant information to our local stakeholders. As I've said, we achieve quite well when we look at AICB benchmarking across the West Midlands and nationally. There are some areas that we can improve, things like the flu vaccinations and school-age immunisations. That's something that we've already identified. We need to work much more closely with our providers who provide vaccinations in school to increase the uptake of those, and areas such as the vaccinations in the 2 to 3-year-olds and immunosuppressed for flu. COVID vaccinations, because we've obviously had a local implementation really to support the COVID vaccinations, we do have very good uptake on our COVID vaccinations compared to national and West Midlands other ICBs. We have done a lot of work over the last 4 years now, nearly 5 years, focusing on inequality areas, access areas, to make sure that we've got really targeted support for COVID vaccinations, and that we're addressing any inequities that we've got across the patch. We do have a new vaccination that started in September last year, which was the RSV vaccination, which is a respiratory I can never say the synctival virus, so I'll look to Mark for check if I'm right on that one. And that is a virus that is quite common in older people and particularly young children, and it is responsible for a lot of admissions to hospital and unfortunately quite a few deaths as well for both children and older individuals. So that was implemented in September last year. The older vaccination programme is going to be when you turn 75, you will be invited for a vaccination, but there is currently a catch-up between 75 and 80-year-olds for the next 12 months. And then pregnant women will be vaccinated to protect, obviously, children up to the age of 6 months when they start to have their vaccinations. MMR vaccines is something that we do have quite high uptake levels of when we look at ourselves and compare ourselves nationally and regionally. However, across the patch, we saw a significant decline in MMR vaccinations, particularly around, well, I think it has been declining, but obviously COVID periods significantly affected MMR vaccinations. So we have done a lot of work over the last 12 months to make sure we're targeting the areas of very low activity in MMR vaccinations, but trying to improve the general awareness of the significant impact if individuals do catch mumps or measles, to try and get as many patients vaccinated for MMR as possible. We obviously touched on and the previous discussion things about prevention inequalities, and there's quite a few things that obviously link in quite nicely to the Vaccinims programme. Vaccinations is one of the key things in the prevention programme to prevent vaccination preventable diseases, so it will be a key priority moving forward to make sure we're maximising all opportunities. And as part of that, looking at the inequalities aspects of Vaccinims, as I've said, we need to start drilling down on some of these data so we can target a little bit more widely how we can support communities or support particular demographics to come forward for vaccinations, as we do know that there's some areas that we do need to continue to work on. We have done a lot of work on the back of the COVID vaccination programme. We did have specific funding for COVID vaccination access and inequalities. So we've used that experience that we've had with COVID to look at other vaccination streams. So we've been looking at the 0 to 5-year-old vaccinations in general practice. We've been looking at MMR vaccinations and trying to target some of the approaches that we can have to get into those specific vaccinations. As I've said, we are quite good when we benchmark against other ICBs. We are seeing a reduction in flu and COVID this year, and that's similar to what's happening nationally. So we are aware of that. It's something that is happening nationally, and there's a few reasons for this. This year there was a significant lack of a national comms campaign around flu and COVID as we went into the winter season. I don't know if anybody ever saw anything around the sort of national press or coming out of NHS England, but there was definitely not a concerted effort from a national perspective to do a comms campaign to bring people forward for their flu and COVID vaccinations. We have tried to do local campaigns, but obviously that doesn't have quite the same reach as the national campaigns would have. There is quite a lack of awareness of the significance of the COVID and flu infections, particularly around COVID now. People think it's gone away or it's less of a significant issue than it was a couple of years ago. We do still have hospital admissions for COVID, and we do still obviously have flu hospital admissions. So it's something we're doing locally to raise awareness of the significance. If you do get COVID or flu, there is still the risk of being hospitalised or having serious effects of both of those infections. In general, nationally, they're thinking because of all the COVID vaccinations that people have been called forward for, there is what they call vaccine fatigue, which is a term that's being used to say that people have been called for so many vaccines now, they are wondering why they do need another COVID or they do need to have the flu vaccination. So that's something that we're trying to address, to try and raise the general awareness, to say actually it is something that you will continue to need to have on a seasonal basis, and it's not something that you've been vaccinated once and you don't need to have any further vaccinations. So there's a number of things that we're working on at the moment to obviously try to address the areas of concern and to try to improve that vaccine uptake. What we would like to see and support from a council perspective is to obviously raise awareness as wide as possible. You can continue to have your COVID vaccination until the end of January, and you can continue to have your flu vaccination until the end of March this year. So we're trying as much as possible to continue to invite people forward to be vaccinated as quickly as possible. I'll leave it there and I'll open it for questions if that's okay.
Thank you very much for your report there, Samantha. I've got Councillor Charlotte Atkins to start off with. Thank you.
Okay. You seem to have a problem with the second dose of the MMR vaccine. So what are you doing about getting people to recognise that the second dose is important? Now, I think it was actually portrayed on some sort of hospital drama, some TV hospital drama recently, which obviously is helpful. But clearly, if people think that the first vaccine is enough, then clearly you're not getting the message out. So what are you doing about that? Now, you've talked about the relatively low take-up of COVID vaccinations. Are you aware that there was a shortage of COVID vaccine before Christmas, and that some pharmacies, even though they had a booked appointment to give the COVID vaccine, were unable to do so because of lack of supply? And is that lack of supply likely to recur elsewhere? Thank you.
So just touching on the COVID vaccination first, as far as I'm aware, there were no supply issues with COVID vaccination nationally. Each provider is responsible for their own ordering, stock take, etc. But we're not aware at an ICB level of any COVID vaccination shortages, so I'd have to take that away just to double check and I can come back to you. But as far as I'm aware, I wasn't aware of any shortages, but we will double check that.
Well, certainly there was a shortage in leek, because I in fact turned up for my appointment and was told there was no vaccine available.
I can take that away.
So that, of course, tends to mean that you don't go back for another one, and indeed I haven't. So, you know, it's just about making sure that intelligence is getting through to you, because clearly, if it's not getting through, then there's some issues around communication.
No, definitely. I'll definitely pick that up because the COVID vaccination, it's widely available within the NHS. Obviously, the NHS it's purchased at a national level and then obviously supplied directly to providers. We support that process to make sure obviously there's not over ordering or anything like that. But like I say, I wasn't aware of any issues, but I can definitely go and look at that to make sure that that wasn't a problem, and also to look at if it was a localised problem, what the issues was, and to make sure that we address that moving forward, because that's important. From a second dose MMR perspective, it's something we need to continue to work on. We did a lot of work over last summer working with our local authority colleagues. We mapped the uptake in MMRs to school data, and we were able to put on a number of clinics within specific schools where we knew the uptake was very low. We also mapped that and had clinics in things like asylum hotels, we had things in community centres, children's clubs, etc. So we had quite a lot of people come forward for their first vaccinations. What I think we now need to focus on is the second vaccinations, because it is, like you say, vitally important that they have that second vaccination. The first vaccination does give a significant protection, but we need to now focus on that second vaccination to make sure that's complete.
What impact is the anti-vax movement having on childhood immunisations in particular?
I think over the last 10 years, I think that's some part of the reason why the MMR vaccination uptake was reduced. You'll probably be aware that there was links with the MMR vaccination to autism and things. That's largely been completely discredited now, but it takes a long time to get over those questions, don't they, as they've been raised. We have had some anti-vax activity, particularly around COVID vaccinations in children, and we have had, where we've had children's clinics go on, we have had some anti-vax activity that obviously has been dealt with on the scene. But as much as possible, one of our key priorities is to overcome the misinformation that's available, try to get out as much clear information as possible to say why it's really important to get your child vaccinated or yourself vaccinated, and to try and dispel as many of those myths as possible. And we will obviously continue to do that.
Okay, thank you. Councillor Anne Edgeler.
Thank you very much, and thank you for your report. Can you just tell me about the RSV vaccination, please? Are you, does it come from your GP, or do you have to apply for it yourself? Because I know of people of a certain age that's not had it and wondering what the situation is, or whether they're called to have it by their GP or whether they apply themselves. Thank you, Chairman.
Yep, no problem. So they will be called by their GP. So as I said, it was a new vaccination programme from September last year, which coincided with the flu and COVID vaccine, which they couldn't be given together. So when patients turn 75, they will be called by their GP as they turn 75, as one of the routine vaccinations. As I've said, there is a catch-up programme for 75 to 80-year-olds that have obviously gone past their 75th birthday, and GPs are slowly working through that catch-up programme. They've got the next 12 months to obviously call those individuals up, but they very much will be called by the GP. There's no need to actively seek that. They will be called by the GP to have that vaccination.
And can I call Councillor Julia Jessop, please?
Thank you very much, Chairman. Hello, thank you for your report. I totally agree with you. I think everybody's suffering from a certain amount of vaccination fatigue. And I think there's a degree of cynicism in the public as to how effective some of these, particularly the COVID and flu. I think RSV is one of those things that only just come on the radar as far as the public are concerned, and they don't really understand how dangerous it can be. I just wonder whether we have any data of those who are admitted to hospital because of flu or COVID, how many of those people had received the vaccination or not. Because I think if there was some data that could actually prove that, you know, those who were admitted to hospital hadn't been vaccinated, that's quite a powerful message. You know, if you don't have it, that's where you could end up. I just wonder whether we have that kind of data available, because I think there needs to be something to crank up in people's mind. Well, if I don't have it done, this is a real risk. Because I think there is that feeling of, well, you can have a COVID vaccination and you can still have COVID. The same with flu, as we know, they're not 100% effective. So I just wondered whether data was available like that, that if it sent a really strong signal, that actually would ring a chord with the public.
It's not data that I've seen as yet. It's not something that's come out nationally or that I think we've looked at locally, but I think it's something that we could definitely have a look at to see whether we can get something locally. We have, on an ad hoc basis, looked at individuals, particularly a couple of years ago when we were obviously at the very peak of COVID vaccinations, and we had a couple of individuals that were in ITU and very seriously ill, and with COVID, quite young individuals that weren't vaccinated, and we used those as a case study and use their sort of statements, etc., to understand firstly why they didn't take up their vaccination, but also use their experience as a bit of a learning and to share to the general population as the impact that not having that vaccination helped on them. And again with flu, we've had one of our pharmacists actually who works locally had very serious flu just before Christmas, I think it was last year, and she hadn't had her flu vaccination. So again, we've used that opportunity as an opportunity to say, actually, this is somebody who didn't get round to their flu vaccination, had very significant implications because of that had significant implications because of obviously the flu virus itself, and we're learning on that. But I'll definitely take away your point about looking to see if we've got that data to bring that back.
Yes, I mean, it's something that would be fairly simple for hospitals to actually, when people present to hospital, to actually say, have you had a COVID vaccine, have you had a flu vaccine? Because I think it would be very helpful to a range of people to know how effective these vaccines were.
I'll definitely take that back and we can bring that. I can see if we've got any data on it, and if not, we can look to see how we can get that data.
Thank you. Councillor Janice Sylvester-Hall.
Thanks, Chair. I've been curious as well. I was one of those people that started the new year with the flu, same as quite a lot of other people, and I'm glad to hear that there'll be more vaccinations coming out springtime. I'll be certainly one of those who are going to be taking advantage of it in future. With regards to access, I think for me, and looking at how we dealt with a lot of the COVID side of vaccinating people, is how people can access and how easily people can access getting immunisations. So some of those will be through schools. And we've got some quite disparate examples that we're working with here. Where do most of those immunisations actually effectively take place as far as the numbers? Is it the surgery? Is it pharmacies? Is it your supermarket? Because there's that many different places now. And are there any other places that could be offering them? So I'm a big advocate of family hubs. You know, they're so embedded within the communities. Are there things that we could be doing more locally as well to make sure that people have the easiest possible opportunity to be able to get those vaccinations? Thank you.
So overwhelmingly, the majority of vaccinations are still given within GP practices, either in the practices themselves or at PCN level. When we look at the majority of our flu vaccinations, COVID vaccinations, that is the key delivery, the main part of delivery. Second to that is pharmacies. So particularly with COVID and flu vaccinations, pharmacies is very clearly the second delivery of the COVID and flu. When we look at pharmacies, they're only allowed to do certain vaccinations, so they can do COVID and flu. There are some pharmacies across the West Midlands that are being trialled to do the RSV vaccines on a pilot basis, but at the moment it's usually COVID and flu that are the main ones that can be given out of pharmacies. And excuse me, and at the moment, because they're national schemes that are led by NHS England and commissioned by NHS England, that's why we're a little bit stuck from a local level to start to look at how we can widen that accessibility. But hopefully when we move towards delegation, we can start to work a lot closer with our key stakeholders to start to really drive and deliver it where we need to be, which is what we did with COVID. So we had much more of a say with COVID vaccinations, where we were actually going to offer those vaccinations. So obviously we have GP practices, PCNs deliver that. Some PCNs deliver it on a sort of aggregated level. We've got many pharmacies now. I think we've got over 160 pharmacies that are delivering COVID vaccinations. And we also have a targeted vaccination team as well for COVID that's now linking in with other vaccinations, but it's much more established, more COVID vaccination. And they have worked to have walk-in clinics across the patch. So they do regular walk-in clinics at things like fire stations, etc. They have linked into community groups, so they have done some clinics at community groups. But that's very much directed as where we think, where we know we've got low uptake, so if it's a particular demographic area or a geographical area. But there's much more we can do to make sure that we get it to the really sort of key groups, really. You know, if we're talking about 0 to 5-year-old vaccinations, we need to be getting into those sort of mums and baby groups, and obviously getting people to, you know, if it's not giving the vaccination, but giving the awareness and the education to make sure that that message gets through how important it is to vaccinate those babies.
Chair's busy, I'll carry on. So for me, having arranged it for my parents, I thought the online facility was so easy, and went to the pharmacy as opposed to the GP as well to be able to do that. So, you know, I will be taking my own good actions for myself as well. With regards to the younger groups in particular, and schools programmes, is there something that you could just share with us about how those programmes still operate, and if people fall through the gaps in some of those, where they can go as well? Because I think that that's also important at the moment.
Yep, so the school age immunisation programme hold clinics for flu vaccinations in, obviously, flu vaccination season, and they also do things like HPV and all the other school vaccinations. They hold clinics in specific schools on specific dates, so they will usually do one clinic in a school on a specific date, and obviously the school sends out a letter to the parents to obviously advise on that and to seek consent for the children to be vaccinated. If for any reason they are unable to be vaccinated then, or some issue with their consent happens, there are catch-up clinics as well that the school age immunisation service do. So there are catch-up clinics that are held across the country, across the county even, to enable parents to book onto those clinics to get their children vaccinated. I'm not saying it's perfect, and we can probably do a lot more awareness around that and education, and we can probably do a lot more work on the actual consent process and the getting, you know, the dates and things in school. So it's something that we are keen to work with our school age immunisation provider to work on. But the provision is there. I think we just need to improve on it as we move forward.
And if for some reason they miss the catch-up clinic, can they go to the GP? Is there somewhere else that they can go then to be able to receive that immunisation? From somebody who used to work in schools quite a lot and still have contact with a lot of schools, it's knowing that there's a lot of people also that potentially aren't actually in education as much as what they could be.
I look to Mark for this, but I'm sure they can go to the GP for a lot of the routine vaccination clinic, routine vaccinations as a catch-up. Obviously, the GPs don't routinely do it, but they can offer catch-ups for quite a few of the routine immunisations.
Mark.
Yeah, we do offer those. I mean, sometimes we may have to order those particular vaccines in, but often when we get new patients arrive and we see gaps in their vaccination history, we'll try and endeavour to try and close those gaps off.
I'd like to call Councillor John Jones.
Thank you, Chair. Thank you for the presentation. Thank you for coming. You touched on it in your narrative. There's a perception now that the COVID is nothing to worry about, and I have to say the current strain doesn't seem to be particularly potent, and I've had it myself. Most of my family have had it, I think. But there's obviously it'll mutate, and no doubt different strains will come along. I just wonder what preparations are being made for something that might come along with more teeth than the one that's here at the moment, and obviously it might need another vaccine to cope with it. That's the first thing. We'll do that one first, and I have got another little question as well. Thank you.
Yep, so the COVID vaccination has changed a number of times since December 2020. So as obviously it mutates and the virus changes, we do actually change the vaccine to hopefully preempt that and to respond to that as much as possible. So we have had a number of different vaccinations. Obviously it's still called a COVID vaccination, but they are slightly different to address the change in the variant that's likely circulating at that point in time.
Chair, yeah, I mean, but the point I'm making, I think, is that the new strain might be more potent than the one that's here now. And whilst we might not get back to pandemic levels, we could require a lot of vaccinations very quickly. And is there contingency to do that?
Yeah, definitely. As part of our plans, we obviously have each season, so obviously spring and autumn are the main seasons for COVID vaccinations. We have our core cohorts, so usually the elderly populations are vulnerable, but we also have to plan for the unexpected. So we have to be able to step up a full vaccination programme similar to what we did in early 2021. So there are contingency plans made for that. From a vaccine quantity perspective and a choice of vaccine, that's all done by the Department of Health. So they would obviously work with vaccine providers to choose the most appropriate vaccine and to source sufficient vaccination quantities. But we're confident that if we need to step up a vaccination programme to vaccinate everyone over the age of 18, which we did early on in the vaccination programme, we can do that locally.
Thank you, Chair. If I may, just one other question. I understand why you're focusing on the 4, that obviously that's the majority of people that need stuff, but I was surprised not to see anything on there for shingles. Which can be, in my own experience with my family, I do know how nasty shingles can be, and it's not just having it, it's the legacy of it when you've had it. Now, there's been a sort of half-hearted TV campaign about shingles, but I don't think that's stressed what a nasty thing shingles can be. People just think, oh, it's chicken pox, you know. And it is just only really, it's only really a big consideration for the elderly, and I just wondered why it's not on here and what is being done on shingles, please.
Yeah, we didn't include everything. These are the ones we've actively worked on in the sort of last 12 months, really, and that we've had significant involvement in. We haven't actively done much work on shingles. We do need to. I don't have the figures off the top of my head as to where we are with the shingles vaccination, but I can certainly have a look at that and get back to you. And we can obviously look at to see what we need to improve on that, because like you say, it is important that we offer this and get as many people as possible to come forward for that vaccination as quickly as possible. Again, that's an age-related one, so as you turn, I think it is 80 now, you get obviously offered a vaccination from that, and it's quite complex as to how the vaccination's been rolled out, so we will definitely need to look at that in more detail.
Finish off, Chair. I don't doubt that the facilities are there to have the vaccine now. I know that they are, but I worry that people don't appreciate what a nasty thing shingles can be. And I'd like to see more publicity around why you should go and get it if you're over 65 or whatever. I don't know what the age cut-off is. That's my concern, really. Thank you.
Yep, and I'll definitely take that away. Like I say, I haven't got the shingles data in my head, but I will definitely look at that, and we'll make sure that we raise that awareness locally of the need to have the shingles vaccination to prevent shingles, because it is a nasty disease, particularly in the older generations.
Thank you, Councillor Jones. Councillor Steve Norman.
Thank you, Chair. Thank you. Can I just one bit of advice I would suggest to you is actually change the name of shingles, because I always thought it was a funny sort of sounding thing to get, big deal, until I got it, and I stopped laughing then. So maybe shingles ought to have a different name, something sounding more horrible and scary. I think the 2 reasons why you have vaccinations, or there should be, one is to protect yourself, obviously, but the other one is to protect others. And if I can go back to 1665, if that's okay, to the plague in AM in Derbyshire, I'm sure there would have been 100% take up there rather than have to sacrifice themselves, cut off from the rest of Derbyshire on that. But you've also got the psychological problem. I do the lottery every now and again. It's all very rational, except I know every time there's a lottery winner. So that could be me. So those people who are actually reluctant to have vaccinations, do know that somebody somewhere will be affected of a side effect to that. The same with crime. You know, it's not how much how long they're going to be in jail. It's whether they get caught. It's psychological, really. So I appreciate the work that's been done in improving the average in Staffordshire, Stoke-on-Trent, compared to the West Midlands and wider as well. But I just wonder if you can help me with the graph on table 3, which is the one that has the ethnicity breakdown. I'll read it to you. It's just that it says for the white British at the top of the list there, England. I'll just do the England ones because it leaves me space over there. 51.20%. Is that 51.20% of those that could have the vaccination have had it?
So that is for each. So when we look at the cohort, so we will have a set cohort of people that are eligible for the population, and they will be broken down into each ethnicity. So of that cohort who are white British, 51% of the white British individuals have had that vaccination that they're eligible for.
Well, obviously, the worrying thing is the one that is picked up in the report about the ones that describe themselves as Pakistani, Asian, or Asian British Pakistani, which is only 7% or a little bit more in Staffordshire and Stoke-on-Trent. What are the barriers there? Do you know what are the issues there? Because I can see the work that's been done there in the mosques and all the rest of it, but it's still scary that there's such a little take-up. I just wondered what you understand was the reasons why there is such a little take-up from talking to people, or listening to people, sorry.
Yeah, there is a reduced uptake, shall we say, and it's very much cultural reasons that they are quite fearful of the vaccinations, and it's not just COVID vaccinations or flu, it's in general a lot of healthcare interventions they would be quite fearful of, or not be as receptive for as other ethnicities. So that's why we have specifically targeted that group, and we've used community leaders to try and get the messages out. We've done a lot of sessions to try and dispel the myths around the vaccinations in those populations, particularly the immigrants. They quite often associate vaccinations or infections and things like that with their immigration status or things like that, and we need to make sure that we separate that completely. Oh, sorry. With their immigration status, so they're quite fearful if they have infections or anything like that, that it would affect their right to live in the UK, etc. So that's one of the things that we've had back from these groups of individuals. But it's quite wide ranging, and one of the key things is to get as local as possible into those and to get the trusted voices that these individuals will listen to. So that's why we've linked in with mosque leaders, we've linked in with community leaders, faith leaders, and we've worked really closely with some of these communities to actually get a variety of research leaflets and resources in a variety of languages, because obviously that's one of the key barriers that we've got to getting the information across to them in a way that they can understand it. So we've done a lot of translating COVID vaccination leaflets, flu vaccinations, childhood immunisation leaflets to make sure that they've got that information. And we've also arranged for clinicians to answer the questions that they might have. We've had a number of sessions where we didn't even take vaccinations along, but we had a nurse or a GP that were there to answer any questions they have or to relay any concerns that they might have. And that's really worked really well. And we've seen an increase going on from that of people that have come forward for their vaccinations.
I don't mean nasty, but MMR and the myths about that was a GP, wasn't it, who started that, unfortunately. And we'll keep an eye on the USA and see, hopefully, that there won't be disasters there, which there may well be, and they may have a knock-on effect for the good, for actually take-up, but, hopefully that we'd have to find out that way. My last question is just simply, if you're 75 on March the 31st this year, you're entitled to an RSV jab, yeah?
Yep, as you turn 75. So you will be called by your GP.
Thanks, Stephen. You've actually picked up the points I was going to come to. So no, I'm more than happy that it actually comes from committee, because it shows exactly where it would be. So, but I thank you for raising those matters. So going to Councillor Phil Hewitt.
This is going to be relatively short, Chairman, because Stephen asked the questions about the percentage that I was about to. So thank you for that, and thank you for the answer. I will make one point. I get stunned that we have these discussions about vaccinations. Vaccinations have saved millions and millions of lives. But some guy on Twitter can tell us we're all wrong. I just find it absurd. Yes, we do, and I don't mind. I queue up with my age-appropriate friends and residents to have all these vaccinations. I have no desire to die. I've certainly no desire to die of anything that I shouldn't have died from, and I think that's the key to it. It will happen to us all, but why we don't have them, it's absolutely beyond any comprehension, and I've had many discussions with people about this. It is beyond comprehension. Is it 1 in 100 children would die from measles? So you think, oh, 1 in 100, that's not a bad average. So if 500 aeroplanes take off from Heathrow Airport every day, I've just made that up, and and 5 of them crash. And 5 of them crash, you'd seriously rethink about where you fly from to your holidays, wouldn't you? You really would. So because sometimes don't put it in context of where it is. I also wouldn't fly from Heathrow. So why would you not let you have a chance of the measles injections? No, I'm just amazed. I find it sad, Mr. Chairman. I was going to say nothing, wasn't I? But I never said loads that we even have these conversations. That there is any resistance. It just stuns me. Thank you, Mr. Chairman. Thank you.
Thank you, Councillor Hewitt. Councillor Phil Atkins.
Yeah, when I saw RSV, I thought that's ringing a bell somewhere in the depths of my mind, and yeah, and I've just wondered why we've suddenly. I think I might know the answer is why we've suddenly got a vaccination programme for RSV, because I'm not going to argue that it shouldn't be there, and it's about, if you look it up, it's about 70 years ago that it was discovered, and bovine RSV is about 80% of the RSV, and vaccination is a distortion of the Latin vacus, a cow. So we do catch a lot of diseases from animals, and I'm having been a farmer and worked with cattle, I'm just wondering if I'm immune to it. But anyway, that's another matter. But I noticed that you've brought in a programme, and obviously Steve will be getting his vaccination before March the 31st for the 75-year-olds. And is it because people are living longer that this vaccination programme's come forward? Is there suddenly a problem with it, or is it something that in public health terms, and I understand it, that we're going to have to do anyway? Because I find all these arguments about vaccinations quite strange, because at this time of year, with lambing coming up in March, April time, most sheep farmers vaccinate their sheep with an 8-in-1 vaccine. So that the various things that can kill lambs and that people have never heard of, like Braxy, pulpy kidney, blackleg. No, they don't. They have no chance. But if you don't, the chances of living are significantly reduced. So all the arguments about having 4-in-1 vaccines I find quite strange. But anyway, why suddenly has it popped up?
So all the routine vaccination programmes go through what's called the Joint Committee of Vaccination and Immunisation, or the JCVI. So they review the cost effectiveness, obviously the availability of vaccines, etc. And they're the ones that say when it tips the balance to say, actually, this is something we should be doing on a wide scale across the country from a population basis. So obviously that's not a decision that we take locally. It's something that's done at a national level through the Department of Health. And they obviously produce their reports. So they're also looking at chickenpox vaccination for next year. So NHS England will be bringing in a chickenpox vaccination next year, because again, that's at the point where they've found out that it's much more beneficial to have that, and they would set the parameters of who's eligible and where the best return for obviously the investment comes from.
That triggers another question, I'm afraid, Chairman. And that is that I understand that, with chickenpox, certainly one of the effects of COVID was that children weren't getting immunity by going to chickenpox and mumps parties and all that sort of thing. Is there a locally an RS? I noticed we've got above average vaccinations, slightly, but have they identified certain areas where it's a problem, urban, rural or whatever?
I think it's a general problem. I think it's very contagious. RSV, so obviously wherever it happens, it's a very contagious infection. So it's a case of getting as many people vaccinated as possible. Because it's a new campaign, we're obviously trying to get, like I've said, as many people vaccinated as possible. As we go into next year, we'll be looking at the low uptake areas to try to focus on them. But at the moment, it's letting the sort of the initial phase run to try and get as many people through as possible.
Okay. Moving on. The question I've also got in my head is in the flu jab that we've had, the vaccination. We've got a lot of increase in flu going into A&E and so forth. So have we got the figures in the sense that the flu vaccinations are down compared to the intake that we're having at hospitals, A&E, and obviously then put on wards as well whilst dealing with it? What's the correlation between the two?
It's difficult for the direct correlation. Flu vaccines are a little bit down this year. Again, it ties into the sort of vaccination fatigue that we're seeing. Particularly last year, we saw really low uptake of flu and COVID in healthcare workers, especially. This year, we've actually seen an uptake in the vaccination healthcare workers and frontline social workers, which is really good to make sure that they're protected and obviously to reduce the transmission of infection wherever possible. We do monitor the admissions to hospital with flu. Early indications are that the flu vaccine this year is quite good compared to the strains that are circulating from a flu vaccination perspective, but there are still obviously admissions to hospital, and we need to understand where we can improve vaccination rates to try and reduce that as we move forward.
Okay, and I think what the follow-up that is that from those that are being admitted, do we know that they did not take the vaccination?
That's what I'll need to go away. It's similar to the previous question with COVID vaccination. I think that's what we need to start to unpick locally to see how many instances that are going into hospital with these infections aren't vaccinated against them.
I do ask those because I think probably in future campaigns it's probably relevant to work it out that you actually then could campaign for people to take that vaccination, obtaining those figures of COVID and obviously well, all of it, I mean, it's very simple in a sense that the discussions on the vaccinations today with MR and the RSV and everything else is getting those figures of those admissions, and sadly if those people have passed away from it, is knowing whether they did or not, and in terms of future campaigns. And I think the programme was highlighted in drama was last night's measles in the Call the Midwife, and I think it probably did spell out to probably those people, that should get their children vaccinated because of the complications and seriousness of not. So I suppose it all helps in that elevation of the do's and don'ts. And I take Councillor Phil Hewitt's point. Why wouldn't you not? I mean, that's the point. Why wouldn't you take those vaccinations if they're going to save lives? So it's important. So rounding that up then, thank you very much, Samantha, for going through that with us. Again, I think we spent a good amount of time on that, which I think shows value in the scrutiny process. Again, I think it's probably one of the ones that we'd like to see again in the future, to ensure that we're keeping on top of it, as I said before the last item. So thank you for your reports, and we'll move on. You may wish to obviously leave at this point, members of the ICB. and we'll let them disperse. But thank you very much for your participation and your answers to questions. Greatly appreciated. Okay, so moving on to our agenda, item 6 is the district and borough health scrutiny activities. Obviously the report is self-explanatory. Are there any points or additions you may wish to take? If I can just call on Councillor Norman Litchfield.
To say that we have now got the health health scrutiny task group. 2 items to be looked at specifically are, and I'm not going to do too much of this, but initially we need to look at the Samuel Johnson maternity services, just because that is so very local. I understand the arguments that we've had. We've had some good papers here, and Janice Sylvester Hall will be there as a county council representative. And the other issue is the closure of the Health and Wellbeing Centre in Burntwood, for which there is no replacement, and which that building is now illegal because it's not compliant with plan permission. But don't get too far on that one. We'll report back. Chair, thank you.
Councillor Anadger, Stafford.
Yeah, just to mention that we've got a task and finish being started to look at food waste, actually, because that's going to be implemented soon. And just to mention also that I went to the Viola for Ashes place last week, actually. I was blown away about the way they distribute the waste, and nothing is wasted. I couldn't believe that, actually. So if anybody's interested in doing that through their district councils, you know, please do it, because I was absolutely memorised. And the other thing I wanted to mention, Chair, if I possibly could, is I visited the stimulation unit at Midland Partnership Foundation Trust last week. But following on from that, we had an offer from the gentleman that runs the unit at Staffordshire University on Blackheath Lane to look at all the equipment, and that I think I've sent you an email, actually. So I just wondered if it's something that the committee would like to do, because he's quite happy to show people around of all the different things they've got there. So I'll leave that with you, Chairman. Thank you.
I do have that email, and I will respond to that and see how we can fit it into probably on the going forward. Have we got any more additions to leak? And yes, John.
Thank you, Chair. Just on staff on the SMDC one, Councillor Atkins alluded to it earlier on. We are keeping the progression of the UTCs in view, and because we think, despite what's been officially said, the MIU is still at risk at leak. And the other one I wanted to just mention was we obviously keep West Midlands Ambulance Service on our agenda as well. And I've been quite, as you know, quite critical about West Midlands Ambulance Service in the past. But on Friday last, I was unfortunate enough to have to go in an ambulance with an elderly relative to Stoke. And the ambulance came quite quickly, to be fair. It came within an hour, which is still not good enough, but it's better than it's been. But when we got to Stoke, we were sat on the ambulance for 6 hours. And this relative's 90. We were sat on the ambulance for 6 hours. Now, I'm not being critical of the ambulance service here. I'll come to the point in a minute. But we had a 6-hour wait, and I counted there were 28 ambulances on that ramp on Friday afternoon at tea time. 28 ambulances, which meant there were 56 ambulance staff looking after 28 patients for the hospital. For the hospital. Giving one-to-one care, which they wouldn't have got if they went in the hospital, to be quite honest. But it's disgraceful because there's obviously no running water on the ambulances. And West Midlands Ambulance Service officers were coordinating all the triage and the transfer from the ambulances into the triage. And it occurred to me, without West Midlands Ambulance Service, A&E would collapse at Stoke. I don't know what it's like anywhere else, but certainly at Stoke, it would. I know they've declared another major incident. And I was just thinking, the work programme doesn't go, we're on to work programme in a minute, I know, but that doesn't go past April. But I just think the next time the RCB come here to report on emergency care. Whoever sat in that chair, and it might, with the greatest respect, Chair, it might not be you after April, but whoever it is, perhaps we should get a peg in the ground and have a joint session with the ambulance service. I think that would be very productive to find out what can be done, or what we can investigate what can be done. Because it's the hospital. I mean, there's no doubt the ambulance service isn't performing very well. But this hospital delay thing is absolutely crippling them. And without them, the hospital at Stoke, at least, would collapse. So I just wanted to get that peg in the ground, if we can maybe get them both here and have a chat. Thank you, Chair.
Thank you, Councillor Jones. Regarding, obviously, the moorlands there, I assume that you'll be just looking at the performance for Staffordshire and how it affects the Staffordshire moorlands. Yeah.
Panel, we talk about the moorlands. I just wanted to make that point because their reason, the ambulance service's reason for performing poorly is always primarily hospital delays. And I have to say, until I witnessed it with my own eyes on Friday, what was going on, it's not just the fact that the ambulances are being held up, but without the ambulances, the hospital A&E operation would just fall through the floor. It really would. Well, I don't think people realise that.
Okay, I take that point on board, and I think obviously we're acutely aware that obviously through a county issue of how the West Midlands ambulance services are. So I think for sure that in terms of a future work programme, it will be revisited. Yeah. 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 Okay. Yeah. Okay. I think in that sense the roundup then on the district and boroughs is done, unless anybody else has got something to say on it, but I would probably think we can move on to the item 7, and that's the work programme. So any items on the work programme? I know we're coming up towards the end of our municipal year, and in fact, Councillor Steve Norman.
When do you actually look at the next work programme schedule? When's that table for?
Yeah, so it'll be down to the new committee, the committee from May that will determine its work programme. So this committee can make recommendations, and I just wanted to highlight something that Councillor Jones had just mentioned, in that if you have a look at the bottom of the work programme, there's a section on items for future scrutiny. Now, that's something that's come from this committee that will then get passed to the next committee for them to consider if they want to look at it. And there is system pressures on there, which involves the West Midlands Ambulance Service and hospital discharges and things, because obviously it's a really complex piece. But that is something that is on the long list for the committee next year to consider.
Thank you, Chair. If I could just draw attention from the work when we issued the Women's Health Strategy Working Group meeting and the recommendations, we've got replies from the various stakeholders who we consulted with, and I have to say a big thank you to those who have sent over details that show what work has already been started, what work can be started, and then other possibilities that are also in the pipeline. I will just share with the committee that following the publication of the report, a large pharmaceutical company, well-established pharmaceutical company, made contact with us with a view to supporting the delivery of recommendations, and that's something that I'm keen to explore further with all the relevant stakeholders, and conversations are ongoing with those as well. But I'm appreciative of the support therein. Thank you.
I think that may be it then. So I'll duly, well, first of all, thank you all very much for your contributions. Not every member has spoken today, and I think that shows the value of what we're here for. So on that note, it being 22 minutes past 12, I duly close the meeting. Thank you.